Ivan Modwala, the sector leader and partner healthcare EY India. Joining him in the panel, we have our speakers, Mr. Gautam Khanna, CEO, PD Hinduja Hospital and MRC, Ms. Dr. Suchin Bajaj, the founder director of Ujjwala Cygnus Hospital, Mr. Abhishek Kapoor, the chief executive officer of Regency Health, Mr. Gaurav Bagga, the senior vice president, product and engineering, Pristine Care. Over to you, the moderator, for the rest of the session's proceedings.
Good afternoon, everyone. So before we start on the very esteemed panelists here, let me give you a little background of why we have the session. So firstly, I have to say that once we do the introduction, I think, Ivan, you are doing the introduction?
Moderate for the panelists.
You will do that. So you will know the kind of knowledge and expertise we have in this panel. But one of the reasons why we took this topic is because you've heard in the first few sessions in the morning of how healthcare is changing, and healthcare is undergoing transformation in the country. And much of that, and I'll give you some statistics which I have to thank Ankur for that, is so I translated from billion to crores. I can't understand billions. so currently healthcare market from 4 lakh crores roughly will become 10 lakh crores. So that's the number to be remembered, out of which significant portion will come from cities, non-metros in the country. So that is where the growth is going to be. And because we have a shortage of the physical infrastructure and the human resources, we will need a lot of innovative ways of managing the hospitals in these places. The other thing we have to see is that once the healthcare sector is growing in these markets, you also have to understand that the healthcare is a very capital intensive sector, and many of these towns may not have the paying capacity to pay the same rates as they would have been in the metros. So that means the business model, what is applicable in a Bombay or a Delhi or a Bangalore, may not be applicable in Jabalpur or Agra or some other place like that. So what needs to be done differently to see how they are run well? So we will have panelists talking about that. The other aspect you heard in the morning, I think somebody talked about, was the major shift in the demographics, where there's a huge growth of middle class happening in the country, which is also going to happen mostly in the non-metros, because metros are full. But if you say metros are also growing, yes, but let's take NCR. In NCR, Delhi is not going to grow, but Gurgaon and Manesar and Faridabad and Noida and Greater Noida. So those Greater Noida will probably be considered as tier 1. I mean, they won't be considered as metro. So in my definition, that's where the population is increasing. And so now the other thing we have to think about is that in this transformation, what are the levers which will be used? And we will have some experienced people sharing their examples of how they have successfully run hospitals in these cities. But before that, I'm going to welcome Kaivan. Kaivan is the partner and leader in ENY, and he is the moderator for the session, and he will take over from here. Thank you, Kaivan, and look forward to the session.
Right. Good afternoon, everyone, and welcome to all. I think just to set the context, and we discussed in the morning, we today stand at 1.3 beds per thousand. What it basically means that if we want to aspire to achieve universal health cover over the next few years, India will need to add 8 lakh to 10 lakh beds over the next few years, 80% of which are going to come in the non-metro, tier 1, tier 2 cities and beyond. And that's going to necessitate an investment, $50-60 billion, even if you take a 50 to 60 lakhs capex per bed over the next few years. So I think since morning we've been talking about universal health cover. but providing quality, affordable, and sustainable healthcare globally can be a rhetoric. But India can become a stellar example to the world of showing it in terms of how it needs to be done. And this will be done by the coming together of three things. I think one clearly, and we heard the eminent speakers in the morning, is political will. The expansion of the Ayushman Bharat program to cover elderly, hopefully in due course to also cover the missing middle, as well as the health and wellness shelters, I think is one big anchor. The second is clearly what you're seeing on the table here, private sector enterprise and ingenuity, with never seen before access to both public markets and private equity capital. Private equity capital, has been the bastion of this sector last 7-8 years. The sector has drawn close to $13 billion in private equity capital over the last 6 to 7 years. Today, healthcare, last year represented 10% of the PE inflows across all sectors. This year, the number has grown to 13%. So 13% of all private equity money goes to healthcare. Pre-COVID, this was just 2%. For the last 3 to 4 years, healthcare has surpassed pharma when it comes to private equity investment. So access to the right risk capital is also going to fuel the growth that the private sector is seeing. And I think the hospitals here are also beneficiaries of that capital in pursuit of their growth journey. And finally, and the most important, I think, is the public demand for accountable care, which is getting powered by the unprecedented opportunities which are there through technology. We've got an aspirational, value-conscious, seeking consumer in these tier 2 towns who's seeking the best of healthcare. So I think when we talk about tier 2 cities, I think one of the key imperatives, and I use this phrase very carefully, is for the private sector to tailor its model for inclusion. This essentially draws from our strong conviction that insurance is a necessary but not sufficient condition for universal healthcare. And therefore, there is a need, and a radical need, for driving operational efficiency through a very focused design to cost approach that the sector needs to do to meaningfully participate in the national agenda for healthcare for all. I think the real transformation in Indian healthcare is singularly, in my mind, contingent on value-based mass healthcare models. We've seen a lot of examples. Regency here is a torchbearer of healthcare in the UP region. Cygnus, has been the crusader for healthcare in tier 2 and tier 3 towns. Quality care, Varun was here. I think the leadership that they've seen in central India, western India, the smaller cities in East India is an example. Kaveri, which is a growing group, started with Trichy. Raj was here from HCG. 20 of his centers are in the non-metro towns. His leadership in the non-metro towns. So I think we've enough and more examples that this model really works. And therefore, I think this brings me to the theme of today's conversation, is how do we really enhance operational effectiveness to drive high quality and cost-effective care at the last mile. And we've got 4 business leaders here who have really created strong business models in this space. I think first and foremost, we've got Gautam. Gautam's the CEO of one of the most loved, trusted and admired brands in India, Hinduja Healthcare. So he's here. We've got Abhishek. Abhishek pretty much has become the most talked about man about UP in the country. I think very quickly earning the sobriquet of being the Pied Piper of healthcare in Delhi, with everybody wanting to enter UP currently. Dr. Suchin Bajaj, has been the founder director of Cygnus Ujala, I think India's largest and most scaled network in over 22 cities, largely in tier 2 and tier 3 and tier 4 cities. And we've got Gaurav Bagga from Pristine Care, the senior VP product and engineering, who's also created a disruptive model to drive healthcare in a different manner. So I think with this esteemed panel, just to set the context, I'll request Ankur to give a short 5-minute presentation on what do we mean or what's the framework around operational efficiency, and then I'll open it up to the panel.
Thank you, Kaivan, for handing it over to me. So I think, like Gautam mentioned, I would just like to, bring the fact that healthcare market today is a, 35 to 40,000 crore market, and it's expected to grow to about 10,000, almost 1 lakh crore, 10,000 billion Indian rupees. And this is a 12% CAGR, almost 1.5 times of GDP growth of the country. And of this, today, metros contribute almost 35 to 40%, with about 20% of the beds. Now, if you see tier 1 and tier 2, their share is going to grow, like Kaiwan mentioned, like Gautam mentioned, there is definite interest in tier 1, tier 2 markets, and a lot of bed capacity is expected to come in these places. And hence, these are the markets who will grow much faster than the overall healthcare market that we see today. So if you look at it in, in a decade, tier 1, tier 2 will be a 6,500 to 7,000 billion INR kind of a market, right? And that's where the opportunity lies. And this is not just because of interest, which I think Ivan already covered, but also for the fact that with the GDP growth, the middle class is expanding. Today, the middle class is around 30% of India's population, expected to grow to about 45% over the next 5-7 years, right? If you see metros, top 55 cities, middle class is already anywhere between 40 to 55% of the total population. And this is the class which is driving this demand, right? Again, insurance is another factor which is driving demand significantly for quality healthcare, and that is where the demand is going to come from. That's where the growth is going to come from for private enterprise. Right today, in the last 4 years, 5 years, almost 10 crore people have got added into the private insurance pool, and this 17-18% penetration is expected to grow to almost 20-25% over the next 3 to 5 years. That's what's driving this demand. However, as we get into tier 1, tier 2 markets, like I think Ivan again talked about, the realizations are 40 to 60% lower than metro cities. And that's where there is an imperative for bringing down the cost structures radically. There is a clear need to bring down 25 to 30% efficiency in the cost structures if you have to sustain in these markets and achieve ROCEs of anywhere between 20 to 25%, which is what anyone will aspire for if they are keen to invest in these markets. How do you drive these ROCEs? So driving ROCEs, essentially, if you see the tree on the right side, so you got to ensure that your costs are, significantly curtailed, and there is a clear, design to cost model there. You are managing your revenue cycle very efficiently, ensuring there are no leakages, there are no, losses which are happening there. You got to manage your capex and bring it down by ensuring that your square feet per bed is optimized. Your cost per square feet is also optimized to the tier 2, tier 1, tier 2 model. You can't really work with the kind of capex which happens in metros, 1 crore, 1.5 crore, 2 crores, which is what you see in the papers. A metro model is very different. A tier 1, tier 2 has to do within 50, 60 lakhs, 70 lakhs per bed kind of a cost, really to make it viable. And looking at frugal medical technology on capex side. And obviously on working capital, ensuring that your debtors are optimized, your receivables are optimized, and your inventories are optimized. Now, coming to material cost, clearly compliance management, around formularies, around ensuring consumption, around ensuring the fact that there is no wastage happening. And, especially when we talk about Ayushman Bharat, we talk about schemes. These are prevalent in tier 1, tier 2 cities. Most of the patients are covered in these, right? And these are packages, essentially, which are there. So you don't really get paid for whatever you consume. You have to limit your consumption. And hence that compliance management becomes really important. Standardization becomes really important. Almost 15 to 20% savings can be brought in just by ensuring that you have demand management and compliance management properly laid out for your organization. And similarly, on the consumption side, if you can ensure that packages like, PTCA, CABGs, TKRs, and many more across specialties, if you can do kitting, you can define what is needed, you can align your doctors to ensure that they are using only what's needed and there's no wastage, which is happening as part of the process. I think the cost can be brought down by almost 30 to 50% for a lot of these packages. And there are examples, if you see on these, which are exactly, depicting the same. How is this possible? It's very important to have your data in place, your technology in place to be able to track this. The only way you will be able to track and control is by putting in the right technology around this and ensuring that you have full visibility of what is happening in your organization. Otherwise, it's very difficult to understand where the leakages are happening and how do you really control them. On the revenue side, again, very important that you understand the whole revenue cycle management. And again, going to tier 1, tier 2 markets, we talked about affordability being a limiting factor in these markets, and that is where you need to champion how do you manage schemes, how do you manage credit business, which is either the insurance business or the panel business or Ayushman Bharat. It could be CGHS, ECHS. Now, each one of these, till we get to the claims exchange, which is proposed by ABDM, have their own ways and means of managing their credit process, right? You need to know what kind of bills to be created, what supportings to be put together, what's to be submitted, how do you do query management and ensure that if they are asking any questions or any additional documents, they are supplied promptly to them. And the submission happens timely, and then the follow-up and then settlement. So again, there's a whole process around it, very critical to put that process in place to ensure that your whole receivables cycle is managed, which takes care of leakage at the revenue side and also takes care of your receivables, your debtors, so that your working capital does not go out of control. Again, very important to the overall frugal model. And on the revenue side, last but not the least, again, digital will be a very, very important factor on growing your revenues faster in these cities as well. We all know that today, the population, even in tier 1, tier 2 cities, is very digital savvy. Everyone has a mobile phone. They are all using digital. They're all going online and seeing their doctor. They want awareness. They want content. If we can provide them the right awareness and look at the whole cycle from awareness till the post-therapy, ensuring they get the right information access, and then from there on, we give them the tools to take appointments. From there on, we manage their whole care cycle end to end. And from there on, just kind of keeping them engaged once their care is done as well, so that they have a full wellness, continuum covered, I think will be very, very critical to ensure that we are able to, in the tier 1, tier 2 cities, the providers are able to kind of get the whole, engaged patient there, and the wellness and the needs are taken care of. So I think with all of this, I think I hand it back to Kaivan to, start the panel discussion.
Thanks,
Thank you.
thanks, Ankur. And I hope this serves as a good context for what we're going to discuss going forward. So let me start with Abhishek first. I think, UP, as we all know, is India's most populous state. 18% of the population, Abhishek, resides there. Chief Minister has set up an ambitious 1 trillion GDP target for the state. I don't think there's a single network or chain in the country who has not defined UP as a critical and anchor growth state, for them. You're the largest provider in UP. You plan to expand by 3x or 4x. So 2 questions. What is making UP so attractive and hot? And how do you view the opportunity in UP, between 2 cohorts of towns? So one is the Lucknow and the Kanpur, and then you've got Gorakhpur, Varanasi, and then the beyond.
Hi everyone. So, Kaivan, to your question, I mean, the answer lied right there, right? I mean, 20% of country's population approximately, right? I mean, if India has to be a 5 trillion economy, UP has to be $1 trillion economy at bare minimum, right? I mean, there is no way we can achieve the larger goal without UP being, achieving its goal. And I mean, in fact, I've seen that journey personally, UP journey. It's been transformational, right, over the last 10 years. 9-10 years back, if you would tell somebody that, hey, I'm operating in UP, they would actually look down upon you like it's a declining state. And today, everybody has a plan for UP, and that's how much the state has actually changed over the last 5 to 7 years, right? So 20% population, which means 20% of the patients in the country are from UP. And ironically, 20% doctors are from UP as well. And we have one of the best medical college infrastructure, because historically, if you see 30 years back, when these colleges were set up, UP was a very, very prosperous state. Various reasons why we couldn't maintain it, but in fact, I mean, you look at the UP cities, you would know of all the 7-8 big cities, whether it be Varanasi or Kanpur or Lucknow or Meerut or Agra. You tell me how many states where you can name 7-8 big cities. You can't, right? I mean, you tell me. Whether it's Orissa, whether it's Bengal, you tell me 5 big cities that you can actually name, right? So that's historically, it was always there, the potential was always there, and it's just that there was a little bit of blip, and that's why, with the right intentions from all stakeholders, it's on the rise, and it's not just healthcare. You look at the metros. I'm talking about the metro rail, the public transport. You look at the expressways. 30% of all the expressways in the country lie in UP today, and I think by next year it will be like 35% or something. And you talk about bank funding, right? In 2016, the cumulative amounts committed to UP by all banks on the balance sheet were like 4%, and we've spoken about this many times. That number is at a staggering 22% right now. So 22% of all the loans that the banks have committed are actually to UP today. And we all can imagine what will the scenario be in 5 years from now when all the investments actually fructify over time. And it's industries, it's plants, expressways, airports, right? I mean, so many functional airports. I could never imagine in my life, even 10 years back, that I would take a flight from Kanpur to Gorakhpur, right? I mean, that's how well the state has become, connectivity-wise. So I think that answers my UP question, right? But now it can't be ignored. Your second question was, how do we differentiate between the bigger cities, Lucknow, Kanpur, vis-a-vis that of Gorakhpur or, Varanasi. Hey, look, so yeah, of course, I mean, Lucknow, Kanpur are a big, big cities, industrial cities, capital cities. I think probably the two biggest cities right now that we could, in UP right now, right? Two things are happening. And Gautam is sitting right here in Bombay. You open a hospital to cater to a 5-kilometer radius, right? And your sales team, and I've interviewed them, like they operate in a 5-kilometer radius network. In UP, you open hospitals for a 250-kilometer radius. So it's not just, what lies in Gorakhpur, but also about what lies around Gorakhpur, right? In a 250-kilometer radius, there is nothing, right? So these are absolutely, barren markets. Of course, as a first mover, it's not easy for us. You have to go and develop the market. You have to make it's a product you're selling for the first time, right? So you have to develop that market. But if you see, there's also income levels are rising, of course. More than that, I think insurance penetration is rising, right? And when insurance penetration is rising, there is a consolidation happening from the smaller nursing homes to larger quality setups, right? So demand, so even if we keep the demand of patients constant right now in UP, if you just use a single lever of insurance, that itself will just transform the requirement for quality healthcare beds, right? And we're talking about quality, and right now that number would be at like 1%, but that number will actually increase. And countrywide, if everybody was insured and there was universal coverage right now, boss beds के तो black में हो रहे होते आज के दिन, COVID वाला हाल हो रहा था कि everybody was insured today, right? So to answer your question, yes, these are not easy markets to go and operate in, but that's where the lies the opportunity, right? To go and do the hard work. It's not an easy baked market that you go and start operating in, but it needs some level of development.
Oh, thanks. So I think from that, it brings me to you, Doctor. I think commendable effort. You've scaled to 16 to 17 cities, even small cities where the population is 3 lakh, 4 lakh, Panipat, Haldwani, etc. How do you view the opportunity in these markets, and what's the uniqueness of the Cygnus model to have leveraged this opportunity so effectively?
Yeah, Panipat is one of our better known towns actually. We are in towns like Sitarganj, Kaithal, Rewari, so towns which even I hadn't heard of before we started hospitals there. I'll put some numbers also to what Abhishek is saying, right? The underutilization of the services. So we all need to understand that healthcare in India is not just underserved, it is under-accessed as well, right? You said there are 1.3 beds per 1,000 and we need to add, 10 lakh more beds. If the beds are so undersupplied, why are the patients being sold like cattle across hospitals and doctors even to this date, right? Why do hospitals have marketing teams? Why does Gaurav need to work with hospitals to, fill their beds that are not utilized? So we need to understand that what Abhishek said, it is a very under-penetrated and underdeveloped market, right? We have one of the lowest hospitalization rates in the world. Does not mean we are the healthiest people in the world, right? The Lancet Commission for Surgery says that a LMIC country like India should have about 5,000 surgeries per 100,000 population per year, on an average. To put it in context, Brazil's number is 13,000 per 100,000 people. Some Scandinavian countries where the out-of-pocket expense is extremely low and awareness is really high, this number is as high as 23,000 also. Now, how many surgeries have we done in India last year? Only about 2.5 crore surgeries. So this number is, in India, is just 1,700. So where are the other patients? They are not getting the surgeries done, they are not getting the treatment done, there is a lot of awareness issues, availability issues, accessibility issues, affordability issues, which insurance hopefully will address. But I'm not very sure. You said yourself that it is only one of the various things that we need to do, a lot of things we need to do. So building awareness, making affordability an integral part of the entire system is something that needs to be done from the very first day. So when you go into these small towns, it is not enough to just build a hospital and sit there and hope that people will come and access your services. It will never happen. You need to go into the communities. You need to build a lot of trust in the communities. You need to completely own the community's entire healthcare life cycle, right from a preventive primary first point of care like digital intervention or a first, PHC kind of a checkup to the entire surgical and post-operative interventions that you do. So I've been attending medical conferences now for almost, I think, half my life, if not more. And in every conference I hear the same thing, that the future is in tier 2, tier 3, the metros are full, the future is in tier 2, tier 3, but nobody's actually going there to set up these hospitals, right? Why is that? Because as I said, awareness and affordability, the fact that the community doesn't want to really pay, it's not want to pay, they really cannot pay. And when they have to come to the big city to get the treatment, unfortunately, 6 crore people every year slip below the poverty line because of these healthcare shocks. It would be difficult for people sitting in this room to realize, but more than 1/4, more than 25% of all patients admitted in India, whether it be in a government hospital or a private hospital, have to either borrow money or sell some asset to pay for their medical fees. It's a huge number, right? So that is why you need to really work with the community to make sure that they come and access your services, and you are offering them very high quality but yet affordable services. That, as Abhishek also said, the quality beds is something that we are lacking. We keep harping on affordability, but accountability, accreditation, those two A's nobody speaks of, right? Everybody is speaking of availability, affordability, accessibility. But accreditation and accountability is something that we really need to work hard on, and that is what we are trying to do. That is how you build trust in the system, and that is how they will come again and again to access the services instead of just the first time when they're in an emergency, when their life is at risk. Obviously, then they have no other choice but to come to you. But how do you make sure that you own the entire life cycle and they come to you again and again? This is the only way to do it.
Perfect. So excellent. So taking on from there, Gautam, right now with your FICCI hat, policies to drive access, to drive awareness. We spoke about the need for beds, but there's such a huge skew, in terms of disparity of infrastructure, whether it's clinical, whether it's the physical beds. From a policy making perspective, whether it's about PPPs, viability gap funding, awareness creation, primary care, what are the 2 or 3 places where the private sector and the government need to be shoulder to shoulder in driving some of these things going forward?
So, Kaivan, after listening to what Sachin just mentioned, first thing I'm going to say that very key thing he mentioned is engaging with the community and not waiting for the emergency situation to get admitted to go to the hospital. So that means there needs to be a mechanism that they come for some kind of preventive care things. This is where the government can come in. That government can do some incentivization that the hospitals in tier 2, tier 1, tier 3 cities are given some kind of a tax break or funding to take care of the community health, which is what he's talking about. So that will take care of the preventive, that will take care of the footfalls. And also we know, I think in the morning he talked about TTI, I forget what infra he said, but I'm going to put TTII, which is last word is the investment. So the investment is similar. If he's going to buy MRI machine in, which place you said? Kiratnagar. which place you said? Some place he said. Sitarganj. The MRI will be the same as it will cost in Bombay. So it is not that he's going to make it, yeah.
He's right.
It'll be more. It'll more. So it is not that the cost is lower. So that means he has to get some kind of a viability gap funding for the first few years. So that is a policy. Otherwise, the other model is that in all these areas, wherever there is a government, PHCs, secondary care, primary care, do a PPP. Say, okay, Suchin, go and run it. So Suchin runs it, but then the problem is about the government trusting the private to ensure adequate health care. So these are a couple of things, but I'm going to just say one more thing I just remembered. There was this, now the trend is changing that in metros, very difficult to get doctors.
Yeah, they want to go.
They all want to go back to their hometown. And I remember having this discussion with Abhishek, I think many years ago, Abhishek, I don't know whether you remember or not. I do. That he told me that he doesn't have problems of getting good doctors. And I have a problem in Bombay. So there's like disconnect. But then I figured out the reason. And there was another example that in Chhattisgarh, in the Naxalite area, there was a district collector who was able to get doctors and provide healthcare to that tribals, while in the towns it was not possible. So I think that model of what you do, that means you incentivize the doctor and whoever is doing that, what he said, the cost of serving will be high in a non-metro. For example, if he has a 800-bed hospital or 80-bed hospital, how much can he buy? Means what optimization he can do to have discount on bulk purchase? What can he do? So there is a place for PPP. There's a place for VGP. There's a place for some tax break for these hospitals.
Perfect. Gaurav, I think you can also talk a bit about Pristine. I think you own the patient, and then the surgeries are done by our doctors. But interestingly, you use the infrastructure and the latent capacity that exists, which is the 2 million beds today. I think the key is, how do you really institutionalize quality and outcomes at the epicenter of what you do, and how is it different between the tier 2 versus the metros for you currently?
Sure. So I think for Pristine Care, I think the model that we have is we have our own surgeons, we have our own clinics, and we acquire patients also, which is primarily digital only. And what we use is infrastructure of partner hospitals. And that's where I think the theme has been, like, we have to save money, like cost, like 15 to 20% the cost for operating hospitals has to come down. I think that's where some of the contribution comes in from us, where we are also utilizing that infrastructure that is there. I think when it comes to metro cities, I think the people are more aware. I think and they have more understanding. They're more proactive in getting the knowledge. But when it comes to tier 2 or tier 3 cities, I think what we do is we have a care coordinator who talks to each and every patient. So once somebody is reaching out to us digitally, there is a care coordinator who would talk to that patient, explain what the surgery would look like and what would be the challenges, and then there is a consultation with the surgeon at our clinic. So the care is not different. It's just that there is an additional care coordinator who's helping each and every patient in identifying their journey in the surgery, and I think providing more awareness, which probably people in metro may or may not require. But I think even before joining healthcare, I thought I understood how healthcare would work. But I think once I've joined healthcare, I think I had to explain it to my dad, like insurance of 4 lakhs is nothing. You cannot have insurance free, like you have an insurance of 4 lakhs. I think that should be more than like 70, 80 lakhs. So I think even in metros, there is less awareness, but I think with tier 2, tier 3, what we do is we become that partner where we are providing that awareness as well. And with Pristine Care, I think we are digital first, and everybody has access to internet. So I think that's where we are able to touch with the patients in tier 2 and tier 3 cities.
Thanks. Coming back to the Pied Piper of UP. So, I've been amazed, Abhishek, to see what you've done in Lucknow, right? In your first 2 months, 100 robotic surgeries, such a world-class cancer program. I think you do all kinds of transplants. You know, what's the challenge in really bringing this world-class care to a place like Kanpur? And how do you blend the frugality from an operating efficiency perspective, capital allocation perspective, with ensuring world-class care in what you're doing today?
Yeah, so I think Ankur mentioned in his presentation, right? I mean that, of course, the ARPOB is a little lower in these places, and you have to look at the cost model, right? I mean, we all have investors on board as well, and we all are, in a severe expansion phase as well. So the idea is that can we, at let's say maybe a 15-20% discount to a metro ARPOB, can we still deliver a similar EBITDA? And that's what we've been doing for the last few years. That in the metros you would see an ARPOB of upwards of 50,000-60,000. Given that we do all the high-end stuff like robotics and transplants, etc., we are somewhere in the mid 40s and still able to deliver a EBITDA of roughly close to 30% for our mature assets. So I think the entire DNA is different. The way we have structured the organization, the cost, doctor compensation, buying power for pharmacy, equipment, everything. You have to factor in every single thing more than a metro chain if you have to deliver the same level of profitability. So it goes on from when we work together, right? I mean, it's evolution. You start today; it doesn't happen in 5 months, 6 months. It's a journey that over 6 to 10 years. You need to have like 2-3 big cycles. That over these 2-3 big cycles of investment, I will become very frugal. And we started a journey back in the day in 2015, and we're seeing some results now, some significant results. So and it's much easier for a newer hospital to achieve it, but if you're a legacy hospital running for years, I think it starts from changing the culture, and then it's culture first and then cost later. Because if the culture is changed first, cost you're able to capture much easier. I think your second question was on was it on equipment?
CapEx.
Yeah, so CapEx. I mean, we I think somebody mentioned. So we average somewhere around close to with oncology somewhere around 70 lakh rupees per bed. So I think that's again a differentiation. I mean, you need to have a high ROC, right? I mean, so we're not doing, for example, a metro chain would be doing 1.5 crore. So significantly lower than that. Whether it comes to that or square feet, etc. So you have to. It's a everything, every line item that you pick up on your balance sheet or your P&L is an action item for you. Correct. And it's an action item, and you work today, and in 2 years' time, again, it's an action item. So it's a evolution, and you have to keep focusing it. It just has to come into that, it's just a DNA that you have to keep looking at it again and again and again and again and never stop looking at it. Because the day you stop looking at it, they will drive you out of business.
Well said, Abhishek. Dr. Sujin, I come to an important point and a topic which is very close to me. In the morning, trust was spoken about. Varun spoke about credibility. I think the ancient principles of Charak Samhita, Shushruta Samhita, where you treat the patient in the right way, with transparency, with empathy, is I think at the bedrock of any healthcare system. We all know that in tier 1, tier 2 cities, wo jo vishwas jeetna hota hai, wo aur time lagta hai. So what is it that helps us forge trust with the communities? And what are those 3 or 4 simple tips that the audience can take away from there? Yeah, if I have to build trust into my DNA, how should I do it?
I think that is the most important thing to really push on, as I said in the last round as well. And the reason in healthcare why it is most important is because the balance of power is extremely skewed in healthcare. And there's a lot of opacity in the decision making. If you go to a hospital right now and you're on your bed and the doctor says, as soon as you get up and walk out, I don't have any guarantee whether you will survive for 2 minutes or not, right? Heart attack hai, abhi 2 stent dalne hain. Bahar jaoge, mar jaoge, I am not concerned after that. Right now you have to decide. What power do you have in this transaction? Absolutely zero, right? Absolutely zero. You can't say anything. You say, "ठीक है, डॉक्टर साहब डालिए." And that is the reason why patients have so much angst when they come out, when the life-threatening situation is removed, that I had no power at that time, and I don't know if the doctor was right or I was being fleeced. And the fee for healthcare model doesn't help at all in this, because everything is attributed to money making. That the doctor wanted to make money, that is why this was done to me. And that is why you have all this mistrust issues between the patient and the doctor. And wherever you have a fee for service model, this same mistrust will continue. Do you think that European doctors make lesser errors than American doctors or have better outcomes than American doctors? It would be almost the same, right? But Europe, you would hardly see any malpractice suits or patients going against doctors and claiming money, whereas in the US, you will always see it. Each and every case, you will find that people are suing doctors left, right, and center because they feel that it was a money-making exercise that was done. In Europe, they feel that since the doctor was not earning any money out of it, they will assume a mistake instead of malice. And the same thing happens in India. The trust for the legal system is so low that you do not see too many suits. They वहीं पे वहीं निपटा देते हैं, वहीं पे पिटाई होती है डॉक्टर की. कोर्ट वोट कौन जाएगा 20 साल तो. So they have no trust in the legal system. But this issue is always there, that they are not really trusting their doctors. If you cannot build it, then your practice, especially in a small town, will be very difficult to sustain, especially if you are trying to substitute the big city hospital. Right? You are saying that you don't need to go to the big city now. I am here for you. So people are actually trusting their lives in your hands, saying that, okay, we won't go to Delhi. You can treat us for this heart disease or this neurosurgical illness or critical illness. If you don't have that trust, it is very difficult to sustain yourself. The easiest way that we found how to build trust in this community is what I said: try to eliminate the fee-for-service model as much as possible. So try and have your doctors as much on a fixed salary as possible rather than paying them fee-for-service. And it helps us in many ways, right? One, as I said, it disincentivizes unnecessary and unethical behavior, because the doctor is not really getting paid for putting in a stent. They don't really want to put in a stent unless absolutely necessary, right? But also it helps us in a lot of other things. Economically, it helps us a lot, because we work, as was pointed out by both Ankur and Kaiwan, in low fixed package scenarios a lot. Ayushman Bharat, CGHS, ECHS. So if we share each and everything that comes in with the doctor on a variable model, it's very difficult for us to make money at those small package rates. So this allows us to work on a volumes model, that the more volumes we build, because most of our expenses are fixed, doctors are fixed, salaries of other paramedical staff are fixed, building rentals are fixed, utilities almost practically fixed at 3%, 3.5%, doesn't ever cross beyond that. The only expense we incur going forward, which is variable, is consumables. And as Abhishek stressed, that we are driving a lot of efficiency parameters. Kaiwan also is helping us a lot on that, on making sure that consumables, use of high quality generics, bulk purchase of implants. As Gautam said, the purchasing power has to be utilized a lot. So an 80-bed hospital or a 100-bed hospital, of course, has no power at all. But if you have 23 hospitals across 20 cities, you have 3,000 beds, then if you centralize all of these purchases, you have a lot of power. Third, also, what it helps me specifically, maybe not my investors, but it helps to keep the ethos of the organization in place. The organization was formed due to some personal stories. It was not formed to, earn money. I actually dropped out of college to start this. It was not really to earn money. I would have earned a lot more if I'd become the gastroenterologist that I was trying to become. But the ethos of the organization is that no one should die on the road while trying to access healthcare. Right, so it helps us to keep that ethos strong, that anybody who comes into the hospital in an emergency, we treat them. because the doctor on a fixed salary is not really worried about paise dega ki nahi dega. Right? 3 a.m. if a heart attack is coming in, doctor comes in, treats the patient. He's not worried that, whether the patient will be able to pay for this stent or not. That is my job then. So that builds again a lot of trust in the community that, we went there, we were treated, nobody really talked to us ki paise nahi hai to ilaj nahi hoga ya chale jao. So that helps a lot because you can control the paramedics, the nurses, the front office that, only ask for money once. If they don't have money at that time, start treatment and we will bother about it in the morning. You can never convince the doctor to do it if the doctor's earning depends on that. You can't say doctor ko nahi paise nahi milenge. He'll say chodo main ilaj bhi nahi karunga. I will not come at 3 a.m. Why should I come? So the controlling the doctors is very difficult if you don't have the right model in place. So these are some of the things that helps you build trust in the community. Of course, it's a very long process. And as Abhishek also said, culture always eats everything for breakfast, eats your strategy for breakfast, eats your revenues for breakfast. So building the right culture in place, making sure everybody is on board with you while driving this change in the healthcare that we are trying to do, that is the most important thing.
But doc, how do you get doctors like in Sitarganj? What do you tell a young doctor, okay, come to Sitarganj? What's the enticement and
It's very difficult actually.
What's the trick?
Yeah, it's one of our pain points. But see, again, it's very easy to get doctors. So we have now 2 hospitals in Kanpur. Very easy to get doctors there, even easier than Bombay or Delhi, as Gautam said. But very difficult to find doctors in a very small town because the level of urbanization is not enough, and those small towns do not have medical colleges.
Yeah.
So any town you have a medical college,
That's fine.
very easy. But if you don't have a medical college, then it becomes very difficult because of 2-3 things. One is, as I said, the level of urbanization. What are the entertainment options post work, right? Where are your spouses going to relax and recreate? Where are your children going to study? These are the questions that every doctor will have in their mind. So very difficult to convince them to come to a town where none of these basic facilities exist. So again, as I said, the first thing is, of course, money. So the young doctor who comes to our small town hospital compared to what he was earning in a big city hospital as a level 3 consultant, right? Every big city hospital will have 3 levels, right? One is the top level, the superstar consultant who's on TV, as well as measuring the Prime Minister's blood pressure, as well as doing 20 surgeries a day apparently. So that is the star doctor there. The second level is the people who are really doing the surgeries, very complicated work. People from all around the world are coming to them. They're very happy professionally. Maybe they don't have a name, but they have a big name in the medical community. We know that, he's the real surgeon there. The third level is the person who's finished his super specialty DM MCH degree, worked for 1 or 2 years as an assistant professor in a medical college, and then come to the big city to start working there. Unfortunately, the salary is very low right now. They have no professional satisfaction, zero independence of work. They are not really operating. They're doing the scut work, the paperwork, arranging the blood tests. When they go to the rounds, all that they hear from the patients is, oh, I came to see the big star doctor. Where is he? He hasn't seen me for 3 days. My tea was cold today. My bedsheet has not been changed. This is what, he's hearing. So he's a glorified telephone operator mostly. We offer them a much higher salary, which is mostly fixed. So second, we offer them independence of working, setting up their own department. A lot of professional satisfaction they get because they get to form their own protocols, policies, and they have no revenue pressure because there is no variable pay or very minimal variable pay. And they suddenly become the stars of that town when they go there because the first cardiologist in the city, the first cardiothoracic surgeon in the city. So everybody is queuing up to see them, right? That everybody wants to consult them. So they have a lot of professional as well as financial satisfaction. And of course, the Delhi pollution helps us a lot. So AQI 420 right now. So all these people are usually late 30s, early 40s, have small kids. They don't want them growing up in this polluted atmosphere. Every child has asthma or something. So we offer them that, they've mostly come from small towns. We offer them that earlier you had nowhere to ply your trade in. There was no hospital earlier there. Now we've set up this NABH accredited high quality hospital. You can set up your own department and come and have a good life, comfortable life, no travel time, no pollution, very high pay. So these are some of the things that get this transaction to be very sticky. So most of our senior consultants stick to us for a very long time.
Excellent tips. I think before I open up to the audience, last question for Gautam and Gaurav together. I think technology, which will play a role in democratizing care. You know, we've already crossed 675 million Aadhaar registrations. 5 lakh doctors are linked. You know, 2 or 3 points or a prescription for the industry on embracing tech in everything that they do. 2 lines each.
I think for us, because we are a digital acquisition like the patients that we reach out to us are mostly through digital acquisition. So whether it's our SEO, SCM based ads, or it's our patient app, and then the whole journey that happens for a patient, irrespective of wherever they reach out to us, it's the same care coordinator that talks to them. I think that's where technology is going to play a very important role, and I think one of the slides that Ankur showed was also the integrated CRM and everything that was there. I think that's where technology plays an important role, and things like AI, Gen AI, and chatbots are really popular right now. And our patients, like the conversations that we do with our patients by the care coordinators, they are transcribed, translated, and then meaningful insights are also taken from it, because there is Gen AI that is there that's powering such help. It's giving us so much help that we can look at what our care coordinators are talking to the patients, and whether the information that they've shared is meaningful, accurate, and whether it's going to help the patient or not. So I think technology, I think it's really helping the business. And one of the slides Ankur had was like there is a 10 to 15% benefit of using technology. I think that's definitely there.
So in addition to what Gaurav said, I would like to just say that the technology, what is being used today, will help the sector by 15, 20, 30, 40%. But if you want real transformation, we have to ensure that the delivery of healthcare, which is today physical, can it be done digitally? One little example is telemedicine, but can you extend that the patient doesn't have to travel and the physician doesn't have to see face to face? Can you do that? That transformation is one thing which will help the sector. Second is the ABDM. I think more and more people should adopt that, because then you will have easy intraoperability of the your personal records. You will own the records and you can move from one doctor, one hospital to the other, and that will give you a lot of ease and quick care. So I think technology will be a very critical factor.
Thank you. Any audience questions?
Most doctors, when they go and work in rural areas, suburban areas, tier 3, tier 4 cities, they face a challenge from myths and misconceptions which are propagated by quacks and RMPs who are ruling the roost there. Is the corporate sector penetration into this sector, into these areas, also facing this challenge, or this challenge is faced only by individual doctors going and trying to work there?
Thank you very much, sir. Yeah, I mean, that's a challenge that all of us face, especially when we are just into that town. When we are very new to the town, the community doesn't really recognize us and they trust their quacks and their, alternative practitioners more. And that is why I said we need to really work with the community a lot. We need to go into the community ourselves and try and dispel those myths and create more awareness, make sure that they access the healthcare better, they improve their health-seeking behavior, and they do not listen to those myths. So the program that we do for this is called the Sehat Chopal. We go village to village every day. Each hospital is mandated to do at least one. Some do 2 Chopals also, morning, evening. One of our very active unit heads does 3 Chopals a day. So in every Chopal we see 80, 100, 150 villagers. We create 2 lectures for them specifically. One is a awareness lecture about the chronic diseases prevalent in that area, which are chronically there, like maybe malnutrition, maybe child stunting, maybe anemia in the women. and one an acute issue being faced in that region in that particular area. Like right now, dengue is a very big issue. So how to save yourself from mosquito bites, when to go to the doctor, when to reach the hospital, and then we screen all of them for all the diseases. So these are some things that we do to build trust in the community. The community will only come to you if they have trust in you. If they feel that if we go to the doctor and they will fleece us, they will charge us 5,000 rupees. Like right now, even in big cities, what happens? You have a common cold. You go to a doctor, it's at least a 5,000 rupee expense, right? The doctor fees, the test that is written, and the medicines that are given to you, 4 to 5,000 rupees. The community cannot afford that for a common cold, let alone for a big disease. So this is how we build trust. It is definitely an issue, and we'll need a lot of time to change that culture.
Last question from the person.
Right. We are talking about operating efficiencies and costs. And in view of the importance of hospital-acquired infections, you must be spending a lot of efforts in maintaining the sterility levels in the hospitals. So how much of this efforts and costs go into CapEx and OpEx to maintain sterility levels in the hospitals? Is there any specific method or just this?
Yeah, so I think what we were discussing about was basically how to make the model more efficient and more frugal. Is your question how much do we spend on? No, so there is no. No, so there is no compromise on the standard operating protocols that we have set for ourselves or that are globally prevalent in across the world. So there are, in terms of fumigation, etc. So there is no, there is no compromise on that. The focus is on better negotiation, better processes, and how can we eliminate waste out of the system. So that's where we focus on.
Thanks. Yep.
No, I don't think it's a big pain point right now. See, whatever it's, I mean, am I saying that hospital-acquired don't happen? Of course they happen, right? But there's nothing to do with the frugality and the cost model of it, right? It's two independent things we are talking about.
Thanks. Yeah, Varun.
Thank you. First of all, compliments, guys. Fantastic session. Loved it. Loved every word of what you've spoken. Question to you, Shrichan. I haven't heard you too often, and today I desperately want to bother you. Culture and credibility. I'm going to pick up the thread that you just responded on. If you go to a Singapore hospital and the doctor doesn't do the tests which bill you $500, he'd come out saying the doctor doesn't know anything. And on the other extreme, you gave that example कि 5,000 रुपए का bill हो गया, doctor तो मतलब चोर है, right? And there are various Indias within India, so you can't say one is right versus the other. And credibility being a two-way street, one is doing right, the other is perceiving right. Where do you think the balance is? And to the word that you added to this culture, when I pick up the newspaper, I don't see that as a healthcare credibility issue, because all of us, what we do, we're not doing it right. We may not be doing it right 1 to 2%, but 98% of the time we're doing it right. But the media report, at least that I see every day morning, doesn't seem to be saying that. So where do you begin from a culture standpoint to fix the credibility issue?
I think you've pinned down the statement you yourself. It's important to be perceived as doing right? So value for money is very important. A Singapore resident may feel $5,000 bill is very less. An Indian citizen may feel a 5,000 rupee bill is very high. It all depends on the value you are perceiving that you are getting in exchange for the money that you are giving. And secondly, most importantly, as I said, the perception that you are not being cheated when you are giving that money. It was not unnecessary, right? People are very happy to buy a Maruti car also for 2 lakh rupees. People are very happy to buy a Mercedes also for 1 crore rupees. That's fine. The value for money I got, right? I have always got 2 phones in my pocket. This is a 1.5 lakh rupee phone. This is a 18,000 rupee phone. This works better for me most of the times. But you don't need to charge it every 4 hours or so. So it's the value that I got out of it. If somebody would sell me this phone for 50,000, I would feel very unhappy, right? So it's the value that you perceive, and that is where the trust has to be built in. That is where the credibility has to come in, and that is why I say the fee-for-service model inherently lends itself to this suspicion, because you do not have enough control over the transaction. And any transaction that you do not control, you will start developing mistrust. So if there is transparency, if the hospitals were to, publicize their prices for all procedures, if they were to publicize their outcomes for everything, that, this is the outcome that we achieve across, and this is we publish every year instead of keeping it completely dark, then maybe, but again, as long as it's fee for service, people will always feel that this was done for money, I did not have enough control. This is something that is inherently built into the model. It will take a long, long time. US is very extremely transparent. Each and everything is documented. Still, the number of lawsuits that you see there against doctors is unimaginable. I don't think doctors are doing too much wrong there either. It's just the culture that is, part of this fee-for-service model, that they were earning money at my expense. I was not having a good time. I was not having a fun time. I was not dining out. I was not having a vacation. I was not traveling to give that money. I was in trouble, and they earned money because of that. There's always a sense of unease around that.
Thanks. I know the gentleman in blue has been putting his hand up, and the lady here. Quick, one last question, and Anupam's really
So my last,
waving his hand there. Last question.
so my question to Sachin sir was that, so the profitable factor is there always. Whenever you see the corporate group of hospitals, they have to earn profit, right? So if we're gonna, fix salary to the super specialists, particularly the clinical ones, and if we incentivize them on the investigations, diagnostics, admissions, they will feel motivated, and the salary, besides, if not on salary, the perks will be very high. And they will be flexible also, because all doctors we know, they have the ego, right? We have to, admit that. And once, once they become the seniors, they doesn't want to be on a payroll, rather than they want to go to the one hospital for a couple of hours. They will go to another hospital a couple of hours, right? So they feel themselves very flexible. And whatever surgeries they will perform, they will earn. And simultaneously, the hospital also earns. Now, if I have a hospital in a tier 1 city, and I will, just fix the salaries, but I would not be getting any revenue from the investigation, diagnostics, and other things, what will be the, the revenue model?
See, I'll give you a very short answer because we are very late and Anupam sir is staring me down. So it depends on what you are incentivizing and what needs of the doctor you're fulfilling, right? Very small example, All India Institute of Medical Sciences, do you feel they have low quality doctors? They have the highest quality doctors in the country, right? They have fixed salaries, all of them. Right? They're not working there for money. They have some other need that is being fulfilled there. So you need to make sure that you are hiring more missionaries and not more mercenaries. So the mission, so they need to fulfill and be on board with your mission rather than just be there for the money.